Hey guys, okay, so this is the video on peptic ulcer disease, PUD. So this is in chapter 55 of our book on page 1107. And so uh, peptic ulcer disease is a mucosal lesion of the stomach or duodenum. And there's three different causes, I guess, three different types. So we have the first one is gastric, which is usually delayed emptying of the stomach. Then we have duodenal, which is in the upper duodenum, and also deep lesions. So, and then the last one is a stress related ulcer. So that one is a less common than the other two. That one is usually from a medical crisis or trauma. Usually a patient who has like sepsis or head injury or a burn patient. They're usually patients that are long-term, they're NPO long-term, or they have increased intracranial pressure. So they are at a higher risk for bleeding. So we will see those probably less often. Many cases of PUD are caused by H. pylori, which causes epithelial cell necrosis, and we're going to see H. pylori kind of all over the place in this chapter. So there can be complications. The one of the most serious ones is going to be hemorrhage, and then perforation, pyloric obstruction, and then intractable disease. So we'll kind of run through each of those complications as well. So these ulcers are also generally going to be near the pyloric sphincter too. So the first one, hemorrhage, is obviously massive bleeding and or minimal bleeding too. If it's massive bleeding, you're going to see bright red blood, or they may be vomiting what looks like coffee grounds. And then if it's minimal bleeding, or they could have occult blood in their stool, or dark tarry stool, the melena. That is chart 55-4. Gives you kind of the key features of upper GI bleeding. So decreased blood pressure, increased heart rate, weak peripheral pulses, acute confusion, generally in older adults, vertigo or dizziness, syncope or decreased hemoglobin and hematocrit. And we'll go over those levels too. For perforation, the biggest problem with that is the stomach or duodenal contents leak into the peritoneal cavity, and then obviously patients can go septic. So that is generally going to have a symptom of very sharp pain. When we do our abdominal assessment, they're going to be tender, rigid, or board-like for the peritonitis. And then generally patients are going to get into a fetal position because they're in so much pain. And then as time goes on, they can get, like I just said, they can get bacterial septicemia or go into hypovolemic shock. And that is a surgical emergency. So not good. Okay, for the pyloric obstruction, and that is usually going to be caused from inflammation, scarring, or edema. They will present with bloating, nausea, or vomiting. And then when they do have a pyloric obstruction, they're going to have vomiting from stasis or gastric dilation. It can't go down, so it's going to come back up. And then If they're vomiting a lot, then that can lead to metabolic alkalosis and hypokalemia. So we want to watch them for that. The alkalosis is from a loss of the gastric juices. So uh, etiology for PUD, a lot of times, especially in older adults, I've found it's going to be from NSAIDs overuse. I actually have a family member that is elderly, and he was taking NSAIDs constantly for joint pain and ended up with gastric ulcer. So they are doing fantastic now, but it did involve a hospital visit. And then the other cause we're going to see most often is going to be the H. pylori again, because when you have an infection that's brewing, eventually that tissue is just going to break down. But when we do our assessment of a patient with PUD or suspected PUD, we need to talk to them a little bit about if they have a history of H. pylori, if they have epigastric tenderness in the midline between the umbilicus and the xiphoid process is generally where we're going to find that. And then the most common symptom is dyspepsia or pressure, feeling of fullness. That is also, let's see, I have table 55-2 marked. So that is on page 1109. And no, I'm so sorry. That's an NCLEX question. Table 55-2 is on page 1110. So there we go. It's going to give you differential features of gastric and duodenal ulcers. I don't know how much in depth we're actually going to go for our exam on this. I don't think it's going to be that in depth. So I would just know basics. They want us to know all the basics. So my husband is being goofball. So, all right, our labs. So I want to talk about H. pylori in particular for labs. There's 3 different ways we can test a patient for H. pylori. And the first one is by doing a blood test. That is the most common, but also the least accurate, oddly enough. So if we do serologic testing for antibodies, that's I've actually been tested for it, and that's how they tested me. So very, very common. If we want to be more accurate, we can go with a breath test or a stool sample. So with the stool sample, they do an antigen test on the stool, and then for the breath test, they do a urea test. Stop that. So they do a urea test where the patient swallows a capsule, and they can put it in pudding or liquid, and it contains urea with a carbon atom. And after a few minutes, they exhale, and they can test it that way as well. I've never actually seen that test done, so it's something maybe we'll get to see in clinicals. The other labs we're going to look at are going to be for the hematocrit and hemoglobin. In our book on page 804, it has all of the blood tests, all of the lab values that are by the book. So for hemoglobin, normal hemoglobin is going to be for females between 12 and 16 grams per deciliter. For males, it's going to be between 14 and 18 grams per deciliter. For hematocrit, for females, it's going to be between 37 and 47%. And then for males, it's going to be between 42 and 52%. So if it's lower than that, they're bleeding from somewhere. So could be. And then we can also look for, pardon me, occult blood in their stool. They can also do imaging. They can, in particular, if we feel like they have a perforation, they can do an abdominal or chest x-ray. The gold standard for PUD is going to be an EDG, where they can get a direct view of the ulcer. They can also do a biopsy and or a cytologic test. My family member that had the gastric ulcer, they actually went ahead and during the EDG, they did the biopsy and they went ahead and used a laser, I guess, and cauterized it. He was fine. But they generally do have to go back after 4 to 6 weeks to have another EDG to see the progress of healing. So let's see. And then if they have GI bleeding, they can also do a nuclear medicine scan. Let's see. Interventions. So for interventions, our patients, obviously, we can do drugs for pain relief to prevent infection and to heal the ulcerations, and then also prevent reoccurrences. The go-to is going to be proton pump inhibitors, but they can also do antibiotics, especially if it's H. pylori. And then if they're allergic to those antibiotics, they can also try bismuth treatment, Pepto-Bismol. And then obviously we've got H2 receptor antagonists, the histamine, and then blockers, and then we've got antacids. So they have a lot of options there. As far as diet, we can teach them to do a bland diet, but per our book, that was kind of controversial. It may not help. It really just depends on what's causing the ulcer, and I would imagine stress management as well, so it's exercise and normal healthy habits. We can also teach patients hypnosis, guided imagery, yoga, meditation. Those were all mentioned in our book. And then there's quite a few supplements too that will help with PUD. Slippery elm, marshmallow root, licorice, zinc, vitamin C, acidophilus, vitamin A, glutamine. There's a couple others, but they can try that. For teaching, we also need to let them know that if they have any sharp, sudden, or persistent epigastric pain, that could be a medical emergency. Also, if they have bloody or black stools, bloody vomit, again, the coffee grounds coming up, then that's a serious issue. And then for teaching, also teach them the symptoms of hypovolemic shock because that can lead to death. And then for our upper GI bleeds, we really want to keep in mind the ABCs, so airway, breathing, circulation. Those are areas we want to keep an eye on, and then also make sure that those patients have, when they come in, if they are having surgery, then we want to make sure they have 2 large bore IV lines, and keep an eye on their values as far as hematocrit, O2 saturation, and vital signs. And then, sorry, this is a long section, guys. We also, as far as symptoms of mild bleeding, we can look for weakness and perspiration. If they lose more than 1 liter in 24 hours, that can lead to shock, which, again, just a reminder for shock symptoms, it's going to be hypotension, chills, palpitations, diaphoresis, or a weak, thready pulse. So we want to make sure we have that committed to memory. For treatment, we can do an NG tube placement, lavage, endoscopic treatment, or acid suppression. And we'll kind of run through those. So for the nasogastric lavage, we need to determine if there's a presence of blood, the rate of bleeding, and prevent gastric dilation, and then administer the lavage. The lavage is going to be 200 to 300 milliliters of a room temperature solution. And how it's administered is somewhat going to depend on your hospital protocol. So it says to reference that in our book. We're going to have the patient lay down on their left side, and then the water coming out at the end of the lavage should be clear or light pink with 0 clots. So that's what we're looking for there. If we do endoscopic treatment for the patient, then what would happen is, this is actually what my family member had done. So they get an EGD, and then they embolize the bleeding artery. So they can do it 3 different ways. They can inject chemicals that would cause it to clot. They can use heat, like cauterize it with a laser. And then they can also use a band or a clip. Now, after they have the endoscopic procedure, we are not to let them eat or drink until we make sure their gag reflex is present. So we need to make sure of that. And again, with the endoscopic treatment, they are going to have 2 large bore IV caths. They will be under moderate sedations. They're probably not going to remember any of this procedure. And then we also need to make sure that they're aware that they could need a blood transfusion. And then they are supposed to be NPO for 4 to 6 hours after the endoscopic procedure. So also another option is interventional radiology. I know some of us have been to the IR lab, so if they're having persistent bleeding, this is where they would go. So if they do end up in the IR area, then they can have a catheter-directed embolization. And it's an endovascular procedure, so they can go in through the femoral artery and inject medication directly into the vessel. So this is only going to be for your persistent bleeders whom don't have curative effects with the endoscopy, and they can also do acid suppression or drugs to prevent rebleeding. So if they do go to IR or they do have the endoscopic procedure, they're probably going to be on acid suppression drugs for a while. And then let's see. Okay, the next one's perforation. So if a patient has a perforation, we want to replace those fluids immediately. That is a medical emergency. We want to document I&O and vitals hourly, and also watch them for symptoms of shock. For the pyloric obstruction, again, if it can't come out, it's coming back up. So they're going to vomit undigested food. They'll also have a feeling of fullness. They'll have distension and nausea. Our job, what we want to do is replace or restore fluids, decompress the stomach. Again, a lot of times that's going to be done with an NG tube, but we're going to clamp the NG tube after 72 hours to see if, to see if they're getting better. Also, we are going to do no more than 50 milliliters in 30 minutes to allow for oral fluids. So see how they do with that. If they have surgery, it's usually going to be with a perforation. For minimally invasive surgery, if we can do laparoscopic, that's better, obviously, because they have a shorter hospital stay, they have a faster healing time, and it's less painful and also prone to less complications. So if they can have the laparoscopic procedure, definitely better. They can do a open procedure as well, but that's just gonna possibly lead to more problems. So laparoscopic is always better. For surgery, again, it's usually with perforation. They can do a subtotal gastrectomy where they take out part of the stomach. They can do a pyloroplasty where they go near, take out. This is going to be really helpful to look at pictures in your book too, but that'll be closer to the pyloric sphincter, a pyloroplasty, and then a vagotomy to sever the vagus nerve. They can do that too. So let's see. And then for home care, we want to encourage the patient to make lifestyle changes, small, frequent meals, avoid foods that make things worse, and then also really educate them on NSAID use, alcohol, smoking, all of those things, stress management. So I think that is pretty much it for PUD. So hopefully that was helpful. We'll take a break and then head into gastric cancer. So thanks, guys. Bye.